Good evening, everyone. I'm really happy to see so many names of people on our list here. I can't see your faces, but I can see your names. And I'm really excited to be able to share with you some information about shoulder and knee arthritis. I'm Dr. Michael Schwepp from Orthopedic Associates. I work mostly in the Rhinebeck and Kingston offices, but sometimes down in Poughkeepsie as well. There we go. Okay, so that's the webinar that you're here for, and we're going to be together for about 60 minutes. What I'll do is I'll talk about. I have a set presentation that I'll talk about for the first part, and then we'll open it up to questions for the second half. So that's me. I'm, as I said, I'm an orthopedic surgeon. I'm currently the chief of orthopedics at Northern Dutchess Hospital in Rhinebeck. My professional background, I graduated from the U.S. Military Academy at West Point for college, and then I went on to the Columbia University College of Physicians and Surgeons down in New York City for medical school, and I stayed there for my orthopedic residency. So I was down there for about 10 years total until I moved up to beautiful Dutchess County in 2001. I do minimally invasive surgery, meaning arthroscopic surgery through small poke holes. We'll talk more about that coming up. I do shoulder replacements for people that have arthritis and other conditions, and the type of surgical replacement I do is patient specific. So we'll talk about how patients get measured and templated for something that fits exactly them. And I also do robotic-assisted partial and total knee replacements. And that's something I'm very excited about. I've been doing that for about 2 years now. This is sort of an outline of what I'm going to be covering tonight. We'll talk about the anatomy of the knee and shoulder. So, how the bones fit together, types of arthritis, how do you diagnose arthritis, and what are your treatment options? So real basic, the knee is a hinge joint, and there are three main bones that make up the knee: the femur, the thigh bone, the tibia, the shin bone, and the patella, or the kneecap. You see the little round patella there. There are some ligaments that connect these bones. They are on the left of your screen, the medial collateral ligament. We abbreviate a lot of things in orthopedics, the MCL. And on the right side of your screen, the lateral collateral ligament. So that's the outside of your knee, away from your other knee. We abbreviate that as the LCL. And then the cruciate ligaments. So most people have heard about ACL tears, really common injury in athletes and even non-athletes. But the ACL and the PCL, or the cruciate ligaments, they crisscross in the center of the knee. And I'm sitting here in the office in Kingston, and this is a knee model. Those bones that we talked about, the ligaments are shown in brown, the rubbery substance. If you look inside, there are the cruciate ligaments. They're called cruciate because they crisscross like a crucifix that's the shape. So the cruciate ligament is inside the knee. So what does the knee look like on X-ray? On X-ray, only the bones will show up. So those same bones that I showed in the diagram, the femur, the thigh bone, the patella, the kneecap, and the tibia will show up. There's a little bone on the bottom there. I don't want to leave that out. It's called the fibula. That's the little skinny bone on the bottom of the screen. Doesn't really get too involved in the mechanics of the knee itself. But that's what shows up on X-ray. The shoulder, moving on to the upper body, is a ball and socket joint. So the humeral head, the upper arm bone, is called the humerus, and the socket part of the shoulder blade is called the glenoid. We've got the X-ray view of the shoulder. The humeral head is the ball of the shoulder, and then the glenoid is the socket. So that's a normal X-ray view of a shoulder. So what is cartilage? Cartilage is the rubbery, smooth tissue that covers the end of bones. This is a picture from a surgery where the patient has an area of missing cartilage. You see the pink rough area underneath, that's where cartilage is missing. The normal cartilage is the smooth white. It almost looks like a cue ball on a pool table, and that's healthy. When that cartilage gets damaged, the bones don't glide as smoothly anymore. So we already showed you these diagrams of the shoulder, and where is the cartilage is where the bone ends meet. Healthy knee and shoulder movement requires healthy cartilage so that the bones can glide smoothly. So what is arthritis? Arthritis is when this cartilage wears down or breaks down for different reasons. And you see the numbers there, 43 million Americans each year. There's a lot of different types of arthritis. And what I always usually tell people in the office is arthritis means inflammation of a joint. So like itis is the medical ending for inflammation of. So appendicitis means inflammation of your appendix. Bronchitis is inflammation of your bronchioles. Arthritis is inflammation of joint. So knee arthritis, we'll start with the knee and we'll work our way over to the shoulder. The symptoms, what does somebody who has knee arthritis feel? They experience pain with various activities, standing, walking short distance, especially getting in and out of a chair, going up and down stairs. That's often the first symptoms. People get stiffness in their knees, especially after being sitting for a while or after being in bed for most of the night. People can get swelling, a grindy, crunchy feeling in their knee, and decreased range of motion, meaning that they're not able to bend their knee fully. And then sometimes people describe sensations of instability where their knee feels like it's not quite solid, not quite holding them properly. So there's two main types of arthritis. Osteoarthritis, the most common type, and then rheumatoid arthritis, which is a little bit more rare. We'll talk about the two main types. Okay, so first, rheumatoid arthritis. Remember I said this is the less common type. About 2.5 million Americans get this each year. It's physically disabling, it's medically disabling. It often involves multiple joints. So you see a little picture of the skeleton. A lot of different joints are involved. Big joints, the knees, the shoulders, and smaller joints too, and the fingers. And what happens in rheumatoid arthritis is that it's an autoimmune problem. So the body misrecognizes the normal cartilage as something foreign, and it activates the immune system to try and clear out that foreign invader, which in fact is the person's normal cartilage. So it starts to destroy the person's own cartilage. There's various degrees of it. You can have very mild symptoms or very severe symptoms. Rheumatoid arthritis is typically diagnosed with blood tests and then treated with medical measures. Okay, I already gave you a preview of this. It's autoimmune, lots of joints at the same time. The synovium is the joint capsule. So you can think of the joint as the place where two or more bones meet, and then the capsule is almost like a balloon that goes around the joint that holds the joint fluid in place. The inner lining of that a balloon is called the synovium, and that gets thick and inflamed and painful. And then you can see in the picture on the right, the cartilage starts wearing away and the joint space gets narrowed, the distance between the ends of the bones. That was rheumatoid arthritis. Moving on to osteoarthritis. Most of you on this call do not have rheumatoid arthritis, but almost everybody, if you live long enough, you'll get osteoarthritis somewhere in your body. It's very common, 10 times more common than rheumatoid. It's less physically disabling. It's not a medical disease. It's a mechanical joint problem. And I describe it to my patients in the office as a wear and tear disease. So, like if you have a hinge on a door, you open that door 100 times a day for 60 years, that hinge is going to get worn out and maybe eventually need to be replaced. It usually only affects one or two joints at a time. Like I said, it's not a medical disease where the whole body is involved. It involves one or two joints at a time. So you see in the skeleton, the knee, the hip, the low back gets involved. They didn't highlight the shoulder for me. I'm very interested in shoulder. We got to fix that, David. So, all right. So what is the progression of osteoarthritis? So I like to think of it, pretty simply as early, middle, or late, or you can also think of it as mild, moderate, or severe. In the early stages, it's mild pain that kind of can come from sports-related injuries. You have minor defects and loss of cartilage. And the pictures of the knees on the bottom right of your screen, the mild is on the far left. So you see it's not completely smooth, the cartilage, the white, there's a little nick in it, but not a big deal. The moderate disease is the next category. People start to have more pain, a little bit less mobility. They have to start changing their lifestyle. They have to stop playing sports maybe they like to do. And what is actually going on in the body is moderate changes to the cartilage. You see the middle two pictures of the knees showing the red areas where the white is worn out. That's moderate disease. When we talk about in the knee, different compartments. So not to get super technical, but there's the medial compartment that's on the inside, closer to your other knee. And there's a lateral compartment, that's the part away from your other knee. So those are compartments. Another compartment is the patellofemoral compartment, where the kneecap meets up with the end of the thigh bone. So three compartments in the knee. In moderate arthritis, you've got involvement in usually one or two of those. When we get to severe or late stage arthritis, by the name, you can see that the pain is probably also severe. It's the main type of arthritis that causes a lot of disability. Usually have involvement in all three of those compartments I was talking about. And it's the picture on the bottom right of your screen. You can see that the red is in all of three of those areas. We showed you before what is a knee x-ray look like. This is the mild, moderate, and severe knee arthritis on x-rays. You see, and what am I looking at? Just, it's kind of obvious when you look at them side by side, but I just want to make sure everybody knows what I'm talking about. We're looking at the space between the ends of the bones, right? Between the thigh bone, or also called the femur on the top, and the tibia, the shin bone on the bottom. You see on the left picture, there's nice space between the bones. That's that dark area. In the middle, especially on the right side of your screen, that's the medial compartment, is starting to get narrow between the two bones. And on the rightmost picture with late or severe arthritis, there's almost no space at all between the two bones. And you may have heard the expression, my doctor told me I have bone-on-bone arthritis. That's not an official medical diagnosis, but this is what those people are talking about when they talk about bone-on-bone. Severe arthritis, very little space between the bones. So what are the causes? Injury, car accidents, sports accidents, one-time thing could eventually down the road lead to arthritis. It's not like you're in a car accident, the next day you have arthritis, but it's a progressive thing over time. Long-term activities like running, a little controversial, because I certainly have seen some patients. I've got some patients in their 70s and 80s that they're marathon runners. Look at their x-rays, they have no arthritis. Other people in their 50s, long-term runners, they get arthritis. So it's not clear. I would never tell somebody just as a blanket statement, stop running. But that's one of the things that may lead to arthritis. Obesity is a big one. All right. So being overweight will 100% lead to arthritis in the weight-bearing joints. All right. So we're talking about the knee, the hip, the ankle, not so much in the shoulder. We'll talk about that next. But being overweight, a common number that I like to quote to patients, it's like 5 to 7 times your weight goes through your knee, especially with stair climbing. So if you're 10 pounds overweight, your knees see that as 70 pounds of weight. So it's also, a positive, because you can lose a small amount of weight and have a big effect on the health of your knees. And then finally, the bottom category there is heredity. So that simply means that if your relatives have had arthritis, you're probably more likely to have arthritis for reasons we understand and we don't completely understand yet. How do we diagnose? When you come to the office, what do we do? If you come in and you've got knee pain, we'll take a history. We figure out, I'll just ask you, first of all, what kind of work do you do? What kind of sports have you done in the past? What kind of accidents, if any, have you been involved in? And then what are your symptoms? How much pain do you have? When do you have it? Is it worse in the morning, worse at night, worse after activities? And, a couple other things that make up what we call the history. Then we move on to the physical exam. And physical exam is just as the word says. I'm in an exam room here. We have you sit on the exam table, and I'll look at your knee, take it through a little range of motion. Physical exam is just looking at the joint, going through a range of motion, checking your strength, checking reflexes, nerve function, see if there's any instability. Some special tests that we have to look for ligament tears. And then we move on to x-rays. And we showed you what x-rays of a healthy knee and an unhealthy knee look like. Sometimes we'll send patients for blood tests. Again, that's more common in a rheumatoid arthritis, that a blood test will be applicable, but we will send for a blood test. The symptoms: pain, swelling, stiffness, and decreased activity. One thing I found with my patients with knee arthritis especially is that they, sometimes a husband will come in with a wife, or a wife will come in with a husband, and the patient may not even notice it or admit to it, but the spouse will say, yeah, he just hasn't been as active lately. He stopped wanting to go to the golf course, or he stopped wanting to help around the house. And so it's a subtle change in lifestyle, subtle change in activities. Joint deformity, there are different types of deformities where people are either bow-legged or knock-kneed, and there's medical terms for that. And that you could be born that way, or you could develop those deformities over time. Swelling, we talked about crepitus. Crepitus is just a medical term for that crunchy feeling that people will sometimes get in their knees. We showed you this. This is the difference between a normal knee x-ray, and the red arrow is pointing to the joint space. Arthritic knee, the loss of joint space. So moving on to the shoulder, the joint space in the shoulder is more of a ball and socket than the knee. As I said, the knee is like a hinge. So a normal shoulder x-ray on the left, there's space. There's a little bit of overlap, but you can see that there's space. The arthritic shoulder on the right, there's a lot less space. And besides the lack of space, we see some bone spurs forming. Those little next, right to the left of the tip of the arrow, there's a little bone spur forming, and you see that there's reaction in the bone. The bone looks angry. That those kind of white areas on both sides, the ball and the socket. So what are the treatment options? Weight loss, big one for the lower body. Not so much for the shoulder, because the shoulder is not a weight-bearing joint. So I don't normally advise my shoulder patients to lose weight for that reason. Home exercise program, we'll give you some simple things to do at home. More involved will be with physical therapy. We send you to physical therapy, and they have a whole program that they take you through, and also give you things to do at home. Ice, very, very effective. When I was a resident, I used to work with the New York Yankees at the stadium, and this is in the late 90s, early 2000s, and all the players would regularly ice themselves up after a game. They would be sitting in a tub full of ice. So what pro athletes know is good for normal people like you and me. So ice is really good for joint inflammation. A lot of different medications. over-the-counter anti-inflammatories are usually first step, and you can supplement that with Tylenol. Very effective for pain. People sort of underrate those because they're over-the-counter, but they're very effective. If you've tried those and those don't work, we can move on to prescription anti-inflammatories. And of course, we try to stay away from narcotics. Everyone's heard about the narcotic crisis that's going on in our society. So the last thing we want to do is get people hooked on narcotics. We will use them after surgery for a brief period of time. Dietary supplements, a little controversial. One of the most common questions I get is, doctor, my friend told me to take glucosamine, chondroitin sulfate. Is it worth it? Is it not worth it? And what I tell them typically is that the scientific literature is mixed on those over-the-counter dietary supplements. I certainly have many patients who swear by these supplements, and I would never try and talk a patient out of using them. But I'll usually tell people if they want to try it for a month or so. If they don't feel any improvement after a month, I would tell them to stop wasting their money. Walking devices for knee arthritis, specifically a cane, a walker to help improve mobility. Braces are very effective in certain settings, especially as I talked about earlier, those patients that have deformities, knock-kneed or bow-legged shape to their knees. So a brace in that setting can be really helpful. We do injections. We do injections both of steroids, a cortisone shot, and we do injections of viscose supplementation or gel. And they both seem to work. Different response in different patients, but I've had very good results with those. And then finally, what probably many of you are interested in hearing about is surgery. But you can see that we don't go right to surgery. We try a lot of different options first before we move on to surgery. I have a question. I am still 2 BMI over for my knee replacement in November. I'm having a hard time getting rid of that 10 pounds because I cannot get around like I used to because pain is so bad. What happens if I cannot drop the 10 pounds? You know, there is no exact rule on BMI. BMI, just to tell everyone, it stands for body mass index, and it's a ratio of your weight to your height. So someone who's 6'3" like me, you know, you can afford to weigh more. But if you're a shorter person, then you can weigh less. And there's that formula we use. Typically, the recommendations are to have a BMI of less than 35 before doing a knee replacement. Some surgeons will push that up to 40, and it also depends on, quite frankly, the hospital rules and sometimes insurance company rules, because insurance companies and hospitals have figured out that people that are beyond a certain body mass index will get more complications. They'll have more infections. They'll have more blood clots and things like that. And so they really don't like to approve surgeries in patients over. And Barbara, my friend, just said body mass index 35. That's high. Yeah, I mean, it's all relative. You know, I'm talking about the sort of upper limits of what we consider healthy. Okay, why is diet weight loss important? Excess weight puts pressure on joints, creates osteoarthritis, and aggravates existing arthritis. It's the lower body, not the upper body. These are the different activities that we recommend. You know, walking super healthy, cycling. You know, you don't have to have a fancy outfit like that person in the slide to do cycling. And a stationary bike is just as effective, probably a little safer in terms of traffic accidents and things than outdoor biking. Swimming, super all around activity, low impact. All those pictures on the left are low impact. And I do want to update this slide for my next talk, David. Put yoga in there because I love yoga. I'm avid yoga practitioner. And so yoga, really good. You don't have to be flexible to do yoga. You do yoga to get flexible and to get stronger, not because you are strong and flexible. Anyway, on the right-hand side are the high impact activities, running and, you know, high impact sports like basketball, things like that. Probably not the best thing for somebody that's got some symptoms of arthritis. So pick from the left side of the screen. Tai Chi, somebody just asked about. Yeah, Tai Chi, very good. My best friend, my oldest friend from kindergarten I grew up with, as a Tai Chi instructor. Yeah, so I think it's very good. It has many of the same benefits as yoga. Question and answer. Ice, we talked about this already. Ice is great. Use ice. We talked about the medications. Go ahead, next slide. These are Tylenol. The generic name is acetaminophen. Very effective. You just don't want to go over the dosage it says on the bottle, but you stay within that dosage. Very effective and safe. It's not addictive. The anti-inflammatory medications listed there, ibuprofen, the brand names are Motrin and Advil, really effective. Aleve, naproxen. The prescription ones are on the right, Celebrex and Relafin. These are good, relatively safe, but you can get stomach bleeding. And so, yeah, meloxicam is a good prescription one as well. But, you have to be a little cautious with these. And certainly you don't want to do it if you're on a blood thinner for something else. You may be on a blood thinner because of your heart or something like that, then your doctor will tell you no anti-inflammatories. All right, we talked about this. This is I already mentioned this. We have a nice picture. These are the controversial areas. They're over the counter. They're food supplements. I tell my patients that, it's a lower standard. The FDA just has, the makers of these medicines, these products, just have to show the FDA that they are safe, that they don't cause illness or disease. Like if you were going to have a new loaf of bread, you just have to prove that it's safe. You don't have to prove that it takes your pain away. So the buyer beware on these. We talked about this, the alignment of the joints, really effective. That's a kind of low profile brace on the slide, but we have more advanced ones that have to be custom made if you have one of those knock-kneed or bow-legged deformities. We talked about that. Walker cane reduces pressure on the painful joint. And these are, this is how we do injections in the office. We do the injections under ultrasound, and that's what I see when I'm giving an injection into a knee. The straight line coming from the right of the screen is the needle, and the little wavy shape there, it looks like a mountain range, a smooth mountain range. That's the bone. So I get the injection, the fluid between the bones. So the injection doesn't go into the bone, it goes between the bones. A couple of different choices for viscosupplementation. It's a mouthful. It just means injecting a gel into a joint. We can do it in the knee primarily, but we've done it in the shoulder as well. But the idea is to thicken up your own natural joint fluid to take a little bit of the pressure off. And we do that under ultrasound as well. And then finally, laser therapy. We've got a webinar on August 11th. My good friend, Dr. Zierman, will be giving a webinar just like this, talking all about that. So I don't want to take any more time talking about it, but just know that it's an option. So moving on to surgery. Arthroscopic surgery is surgery through poke holes, small openings in the shoulder or the knee, usually about a ½ inch. And that's effective for less advanced disease. And then joint replacement is the other extreme, where we actually replace the joint with some metal. This is a drawing of what arthroscopic surgery looks like. Nowadays, this is an older picture. Nowadays, we use just 2 openings below the kneecap, and there's a camera that's on the left of your screen and the instrument, and it's good for mild to moderate arthritis. Absolutely contraindicated in severe arthritis. If you have severe arthritis and an orthopedic surgeon tells you, I want to do arthroscopic surgery on your knee, run away, because it's not effective, and it's just a waste of your time. So when do you think about joint replacement? Well, when you have a lot of pain, it's affecting your normal daily activities, and you've tried all those other options. You should not, as a patient, and I or whoever your surgeon is, shouldn't immediately rush to surgery. You should consider all these other things first, and then if those don't give you sustained relief, then you consider surgery. if you've got a joint deformity, especially like I was talking about the people that are really knock-kneed, really bow-legged, that might push someone to do a joint replacement sooner rather than later because progressive deformity is going to keep happening. What are the benefits? You can eliminate or reduce pain. You know, I try not to overpromise. You know, if patients come in, they have a pain 8 out of 10, 9 out of 10, I'll tell them, you know, I can probably get you down to 1 or 2 out of 10. And that's a big improvement. Definitely enhance your mobility. If you're not walking around much because of a knee arthritis, or you're not moving your shoulder much because of shoulder arthritis, we can restore some of that mobility. Maybe not to how you were when you were 20, but definitely better than what you are when you come in. So yeah, and you can return to normal activities, low impact sports and other activities you like to do, even yoga. What is a total knee replacement? This is the picture of a total knee replacement. It's really a resurfacing. The words there say damaged bone is resurfaced. Many people are confused. They hear a knee replacement. They think we take the whole knee out and put in some sort of robotic bionic knee. That's not really true. Most of your knee or your shoulder remains. We replace the bearing surfaces, the weight bearing surfaces. So in this picture, it's a knee replacement. The femur component, the thigh bone component is up on top. It's metal. The tibia is the shin bone. That's down below. And in between, there's polyethylene. Polyethylene is a special type of plastic, and that acts like cartilage. So there's the traditional treatment hierarchy in terms of surgery. Early stage, sports injuries, arthroscopic surgery, minimally invasive. Early stage, maybe a partial knee replacement. So not replacing the whole knee, but just one compartment. And then the late stage knee arthritis is total knee replacement, shown on the right. That's replacing all 3 compartments. So I told you earlier that I use Makoplasty robotic surgery for my knee replacements. And this is a picture of the computer screen that we use in the operating room, showing exactly what cuts we plan to make and the size of the implants. It's a little complicated, but I just want to point a couple things out to you. On the bottom left, that's a CAT scan slice of the knee, and the green represents the tibial component, and the blue represents the femur component. On the bottom right of the screen, that's a side view, and we can play with all kinds of every possible different angle of the replacement and make it as close to normal anatomy as possible. So this is a picture of a surgeon doing intraoperative registration. So you see in the background there's a surgeon operating on the knee that's bent, and on the screen that's what we see. We see a picture of the femur. So this is after the knee is open. There's an incision in the knee. We put a probe on different parts of the knee and we collect different points. So the robot then knows exactly the shape of the knee in that patient and correlates that with a CAT scan, a CT scan that we got pre-surgically. Then after we've done that, we do some balancing of the knee based on what our plans are. And this is showing how we make the cuts. So this is on the left of your screen, showing a little burring away the worn cartilage, and that's what we see on the screen. It's almost like a video game. My teenage kids will be much better at this when I retire. They'll be pros at this because it's really like a very advanced video game. So that's what a partial knee replacement looks like X-ray wise. And you see the bright white, that is metal, and you see there's nice space between the bones. That space is the plastic that replaces the worn out cartilage. Now moving on to the shoulder. I don't want to give the shoulder short shrift. I love the shoulder. The shoulder is the most mobile joint in the body, but it sacrifices stability for mobility. It can be subject to a lot of wear and tear. We do arthroscopic surgery in the shoulder as well. This is a drawing and then an actual surgical video showing the camera. Now for shoulder replacement, we replace the ball of the shoulder, the humeral head, and we place the socket. And the ball is connected via a long stem, but nowadays we actually have shorter stems. The socket part is the polyethylene glenoid component there, which is plastic that's cemented into place. That's what the X-ray looks like. And you see, you can't really see the socket part because it's not metal, it's plastic, but it's there. There's a little marker, usually a little tiny metal marker, so you can see it on X-ray. So we do the same sort of computer referencing planning for shoulder replacement surgery. This is a picture of a scapula. A scapula is the shoulder blade, and the part of the shoulder blade that is the socket is called the glenoid. So we make our plan based on a CAT scan that the patient has before the surgery, and then we figure out the best place to put the socket, and we get to play with all these different angles. You see the numbers there on the screen, and then the company that we work with actually sends us a bone model. All right, this is a shoulder model. The shoulder blade, or the scapula is the medical name. Here's the upper arm bone. I'm gonna imagine we take all that stuff away, and this is what actually gets mailed or sent to us via UPS by the manufacturer. So here is the actual socket part of the shoulder, and this is a model made specifically for a patient that I did a shoulder replacement on, and this is shaped exactly like that person's glenoid, that person's shoulder socket. So then you see on the right, there is a marker that shows different colors. On the previous slide, it showed the color-coded tool that actually fits onto here. And we set that up and use it in the operating room so that our guide pin for the center of the glenoid, the socket, is exactly perfect. So you may have heard that term, reverse shoulder replacement. In a normal shoulder replacement, or what we call anatomic shoulder replacement, we replace the ball of the humerus, of the upper arm bone, with a ball, and we replace the socket of the shoulder with a socket. In a reverse shoulder replacement, that arrangement is reversed, just like the name says. So we put a ball where the socket was, and we put a socket where the ball was. And why do we do that? Well, this is in cases where someone has severe advanced disease. They have chronically torn rotator cuff that can't be fixed. And with this newer procedure, we can substitute the pull of the rotator cuff muscles with the deltoid. So the deltoid, your main muscle of your upper arm, can allow you to raise and lower your arm in a way that your rotator cuff normally would. So what happens when you have a joint replacement? We're talking knee and shoulder. Typically stay in the hospital 1 to 2 nights. All right, for knee replacement, you're walking usually that day, and you may be using a cane or a walker, but the goal is to get you back to walking with nothing. Now, I usually give the caveat that if someone comes in, they've been walking with a walker for 10 years or 15 years, they may not get back to walking with nothing. But if we can decrease their level of assistance, that's an improvement, get them to walking just with a cane. For a shoulder replacement, you're in a sling for 4 weeks. That's the biggest thing I like to make clear to my patients, that you'll have to be in a sling for 4 weeks after surgery. You will need pain medication, usually some narcotic pain medication for a short amount of time. I try to be really strict with my patients. I tell them, we'll give you narcotics for up to 3 months. After that time, if you're still having severe pain, then something's wrong. We need to investigate further. But I really try to keep people off narcotics. I've had some patients that only use narcotic for a couple of days, but that's not typical. Physical therapy is key to both of these procedures, either shoulder replacement or knee replacement. And depending on your medical condition, you may be able to be discharged from that pretty quickly to a home program, but you need to be committed to improving your range of motion over probably a good 3 months for either one. All right, let's get to some questions. So we talked about the BMI. Yeah, there's no exact cutoff. You know, if your doctor has told you you need to lose 10 pounds, then you know that's a guideline, and of course it's your surgeon's choice. You know, I tell my patients, you know, I am not obligated to do a joint replacement on you, and if my standard is a BMI of 35, then you know that's my prerogative as a surgeon. You know, another surgeon may be more flexible, but it's really for the patient's best interest, because I don't want you as the patient to have infection, complication, or all the bad things that could come from having a joint replacement when you're overweight. Collagen supplements for vegetarians, osteoarthritis. What my typical answer on collagen is similar to what I said about the osteo biflex or the chondroitin sulfate. You know, it's the research is a little scant, and I certainly have plenty of patients that tell me they get really good results from those things, but I don't believe the scientific evidence is that clear. Okay, I've got a question about a knee replacement 3 years ago. Told I need another knee replaced, but I don't have anything like the amount of pain I did with the first knee. However, I can't do lunges or squats, hard time walking on uneven ground hillsides. My hesitancy has to do with the fact that I know 2 people have a second knee replacement and ended up with one leg shorter than the other. I'm interested about minimally invasive surgery and limitations, also robotic-assisted total knee replacement. Okay, so really great question. Thanks for that. Typically, we don't know. In my experience, I have not seen leg length differences so much in knee replacements as in hip replacements. It's pretty common, you know, in hip replacement. I don't do hip replacements personally, but I know from my training and from the orthopedic literature that that's a known outcome of hip replacement. It's hard to get the legs exactly the same length. And the reality is most normal people that have not had a joint replacement have one leg that's a little different than the other. So I'm not convinced that the worry about having a knee replacement, you know, worrying about having a leg length difference is a good reason not to have a knee replacement if you're really a candidate. And yes, possibly this person asked a question, possibly you don't need a total knee replacement on the second knee if your arthritis is not as advanced. Maybe if you've only got arthritis in one compartment, a partial knee replacement would be the right thing for you. You'll be surprised, or you'll be happy to know that the recovery is much quicker, much less involved than in a total knee replacement.
What type of anesthesia is used? Are you actually knocked out with general, or is it, what do you call it?
Yeah, regional anesthesia. So great, super question. So what I usually tell my patients about anesthesia is I defer to the anesthesiologist on that. You know, they will discuss it with you, and you have just like you would come to me or another orthopedic surgeon and have a conversation about, am I going to have a joint replacement or not? What type am I going to have? You'll meet with the anesthesiologist before your surgery, and they will discuss those options with you. Now, I will tell you that the great majority, I don't know, something like 80-90% of our joint replacements are done with regional anesthesia nowadays, meaning that you don't have to have general anesthesia. It really helps out a lot, but there are times where the anesthesiologist will override that and say this person can't have regional anesthesia for one reason or the other. But does that answer your question?
Yes, and I had a second one too. Yeah, this is not an embarrassing question, but I never had one. But I was given a booklet from Dr. Raschenbach. I read that there's sometimes a catheter implanted. I've never had one. Is that something that's done?
Yeah, well, so that's also not, 100%. And you're talking about a urinary catheter.
Yeah.
Usually, we will do that. There's different hospitals have different rules. I think at at Northern Dutchess Hospital, where I do most of my surgeries, it's a age cutoff 60 and above. People will have a urinary catheter, and it's not it's put in after the patient is asleep or numb, so you're not feeling any pain when that's put in place, and it's usually taken out very quickly the day after surgery. So it's not a long-term thing. But yeah, no, it's a very good question, and yeah, it's certainly something that we think about, and we try to minimize our use of catheters as much as possible, because frankly, there's an increased risk of urinary infections if they're in for a long time. But we've gotten very strict on putting them in just for the short amount of time that we need to.
I see. Well, I might as well ask the third one. I didn't put it in writing, but it was regarding donating blood. It was in the booklet too.
Yeah, I'll tell you that's pretty much been it's almost a thing of the past now.
Oh.
When I was a resident in the 1990s, we used to have patients donate blood, and there would be blood transfusions. I can tell you that the number of times that we transfuse nowadays is so infrequent that we don't do that anymore. Improvement in tourniquet use and improvement in different medications that we actually inject at the time of surgery, much less bleeding. So it's super rare to need blood transfusion. I wouldn't say zero, but it's super rare. We do not routinely do that anymore. There may have been an old brochure that you saw.
Okay, great.
Okay, thanks for those great questions.
You're welcome.
My view on regenerative medicine for knee pain. So regenerative medicine, we have two practitioners in our group, Dr. Dentico and Dr. Ricala, who are involved in that. And I would defer to them. That's certainly an option. And the early part of the talk, I talked about all the non-surgical things that you can do. I certainly would if you're getting to the point where you're considering knee replacement, you may want to talk to one of those people. I will tell you that in general, and I'm not an expert in this field, but advanced arthritis, regenerative medicine doesn't have a good track record. For the milder arthritis, yes. I need to have my knee replaced in a few months. I'm very concerned about COVID-19. Really great, relevant, timely question. We, as everyone knows, New York State and most of the states shut down elective orthopedic surgeries while the pandemic was at its height. We're back and reopened to doing elective surgeries like the surgeries we talked about tonight. The hospitals really are, in my view, very safe place to be right now in terms of COVID-19, because number one, the number of cases in our local hospitals are way down. Number two, there's super strict testing and monitoring of everybody that works in the hospital that comes in and out. So, many of you may be working in public places where they check your temperature. I get my temperature checked 3 or 4 times a day and routinely monitored. So, I think it's actually very safe right now. And one extra twist, that if you're going to have a surgery, any type of elective surgery, you have to have a COVID test within a certain number of days prior to the surgery in order to be allowed to come in the hospital. So we're really, I think, Dutchess County is on top of this right now. That may change. The situation changes week to week, month to month. We've got a live question.
What's the purpose of the catheter for the surgery?
Well, the urinary catheter typically is put in prior to for knee replacement. You know what? I should clarify. We don't normally use them in shoulder replacement surgery. All right. So just to clarify on that, because we're talking about both in this webinar. But typically in knee replacement, it's used because with the regional anesthesia, which, as I said earlier, 90% of people have, the bladder control goes to sleep, and then you're not able to to
Control. Okay.
control your bladder. And not that you're losing control of your bladder, but you cannot urinate at all, and your bladder could fill up and could be a dangerous situation. So it has to be drained.
Yeah, I know. I've done before, so that's why I'm asking.
So yeah, so just to be clear on that, yeah, it's no other reason than that. It's usually with the regional anesthesia.
Okay, and then I'm getting surgery in about 3 weeks, a total knee.
Okay.
Is it go home the same day?
Well, okay, so it varies from place to place. We at our surgery center, we have a surgery center in our main office building on Route 9 in Poughkeepsie, where some of my partners are doing same day knee and hip replacement surgeries. So yeah, depending on your surgeon, you might go home the same day. And so speaking for myself, most of my total knee patients will stay one night. You have your surgery on Friday, stay over one night, and then go home the following day after breakfast. A good range of motion to bike without pain and gym is closed. Is rowing machine good? Yes, that is a rowing machine is a great option for total body range of motion. It works both your lower joints, the hips, knees, and the shoulders. So I salute that. Yeah. Another person asks, I'm on a blood thinner. Is Tylenol an anti-inflammatory drug? No. So the beauty of Tylenol is that it is not an anti-inflammatory drug. It is a pure pain medicine. It doesn't thin your blood, and it's safe to use. It's actually one of the few medicines that can be used, pain medicines can be used if someone's on a blood thinner. Okay, I have arthritis and bone spurs in my shoulders. I have decreased range of motion. How does arthritis cause this? So when the cartilage wears out, that's what we call arthritis again. And the body tries to spread out force over a larger area. So when the cartilage is gone, the body senses that, the bones sense that, and they try to spread out the force of the bones rubbing against the bones over a larger area. So the body will try to form more bone, and then actually can become a negative thing. So that's what we call bone spurs, or the medical name is osteophytes. Those osteophytes end up becoming a problem because they decrease the range of motion. Another question, is it true you should put off a knee replacement as long as possible because they last only a limited number of years? Great question. So I'm really glad I saw that question. So all joint replacements have a limited lifespan. The only thing that's permanent is the body itself, because it tends to regenerate. But anything man-made, mechanical, will wear out. So super common question I get in the office: how long will my knee replacement last? There is no one answer. It depends on so many different factors: your weight, your activity level, your sex, your the size of your joint, and then the technical factors are how well or not so well the joint was put in. If it's put in a balanced way, it'll last longer. Which is why I lean towards the robotic-assisted to make things as accurate as possible. But in general, there's a range that's usually quoted of a knee replacement lasting 15 to 20 years, and a shoulder replacement probably the same. Now, if you're in your 60s, late 60s, and your joint replacement wears out, but you may be very elderly and not as active when that happens, and you may not need to have surgery. But if you're young, say you have a joint replacement done in your early 50s, you're probably going to have another one over the course of your lifespan. So that is a consideration. Yes, there is no one answer that you should wait as long as possible. It's a conversation you need to have with your surgeon based on your symptoms and your lifestyle. If you're really very limited in your activities and you're in severe pain, then my recommendation would be to go ahead and have a knee replacement, even if you're a little bit younger, knowing that in the future, you probably have to have another one. So when is a partial knee replacement done? So if you remember from the pictures, I showed a total knee replacement, meaning all three compartments of the knee replaced, and a partial knee replacement, meaning one compartment of the three compartments of the knee replaced. A partial knee replacement is done typically when a person only has relatively advanced arthritis in one compartment. So if you just have a little bit of arthritis, we're not going to do any kind of replacement. But if you have advanced arthritis, but it's only in one part of your knee, you might be a candidate for a partial knee replacement. And then the follow-on question to that I usually get is, will I need to have a total knee replacement later on? The answer is it depends. You know, if you're relatively healthy and you've got a good, well-balanced partial knee, that might be all that you need for the rest of your life. But if you're not that healthy, if you're overweight, you may start wearing out the part that wasn't replaced and then need to advance on to a total knee replacement. Do I need to strengthen my thigh muscles and hamstrings prior to knee replacement surgery? What are the preparations prior and after? Really great question. Yeah, I highly recommend you get in as good, a healthy shape as you can prior to knee replacement. Think of it like you're getting ready to run a marathon. You want to do some training before that. You want to get as strong as possible so that when you have the surgery, you do physical therapy and your body's already primed to do it. Now I get it. And I get this question a lot in the office, like, well, I have so much pain because of my arthritis that I can't really exercise. Yes. So that's where we try and encourage people to go towards those little minimally impactful exercise. Like swimming is a great exercise. I know not everybody can swim, not everybody has access to a pool, but if you do, really great low impact exercise. Cycling on a stationary bicycle doesn't have to be super fancy, but that activity is usually, even someone with bad arthritis can usually tolerate that. I really, really appreciate all your questions, and I apologize I didn't get to all of them. I appreciate you all coming out tonight virtually and joining us. And I look forward to seeing you. You can come see me in the office at Orthopedic Associates, and you can see one of my partners if I don't come to one of the offices that's near you. Thanks very much. Enjoy the rest of your evening and stay well. And I hope to see you in the future. Good night.